Hello, we are live. We are Facebook Live from Houston, Texas. We are here at HPCS. That's short for Houston Plastic, Craniofacial, and Sinus Surgery. This is home to my Houston surgeons. This is home to some of the finest surgeons in the cosmetic, reconstructive, and sinus surgery fields. I'm Morgan Webster. I'm going to be your host today. I'm very excited to talk about this topic. It is October. It's Breast Cancer Awareness Month, after all. And today we are going to be joined by two surgeons, one breast surgeon from MD Anderson. When you think MD Anderson, you think cancer treatment. And we're also going to be joined by one of our very own. Dr. Rednam is here today. Thank you for joining us, Dr. Rednam. You are a board-certified plastic surgeon, and you have a passion for breast reconstruction. You also look beautiful in pink today. Obviously, we're dressed in pink for October, Breast Cancer Awareness Month, but you are doing a lot more than just dressing up. For this event, Dr. Rednam is donating $1 to every comment asked, to every comment made on today's Facebook Live video to breast cancer research. So this is a very generous donation, but it requires your help. So if you're at home watching right now, please just ask away any question. There are no dumb questions. If you are a breast cancer survivor, you're someone that survived this, please type in the comments below and let us know so we can celebrate you and support you. If you're someone who just got the diagnosis that you have breast cancer and you're scared and you feel alone, comment in the comments below and let us reassure you that you are not alone. And let's get into it. Dr. Rednam, I didn't know at one point in my life what breast cancer reconstruction was. I think a lot of people don't even know what it is. So if you would.
So that's part of the reason I wanted to do this talk today, is that unfortunately not enough women do understand what breast cancer reconstruction is. Of all the women diagnosed with breast cancer, only about 50% even learn that that's an option afterwards, which I think is really sad because it is your right. It is your right to breast reconstruction after having breast cancer surgery.
So explain what that means. So 50% of all women who have breast cancer and get a mastectomy and get their breasts cut off opt to not get reconstruction. That's amazing.
So not just people who are getting mastectomies,
Okay.
but people who are getting partial mastectomies or lumpectomies, who are losing part of their breast that still may cause distortion or still don't know their options.
Wow.
And a lot of that comes to education. So that's why we want to do things like this, where we can bring more information, education to our patients so they can understand their options to make the best decisions. When it comes to reconstruction, just giving a general overview, there's two main paths. There's the path that's implant-based, and then there's the path that is using your own body and tissues to reconstruct. A lot of people have no idea that that's even an option, that your belly can become your breast, that your thighs can become your breasts. That's why it's so important that if you do become a future breast cancer survivor, that you get a chance to at least speak with a plastic surgeon to know what your options might be. So those really, when you're going to those different options, it's hard to know. It's a lot of information. You meet so many doctors, and a lot of times your plastic surgeon is the person at the end, as we should be.
The last person you meet in the process.
Correct. We're the last person in the process. We're hopefully the person that gets to help you get back to having your life the way you want it and putting the cancer in your past. But there's also really, really important people who are there at the beginning, kind of like Dr. Reyna
Dr.
here.
Reyna, thank you for joining us today. Dr. Reyna wore pink socks.
Yes. So Dr. Rednam texted me last night and said, "Oh, by the way, we're wearing pink." And since I already had my outfit picked out, I made sure to get the pink on.
Thank you for showing your support.
So I am a breast cancer surgeon. I'm actually a breast surgical oncologist. Most people don't understand what that means, so I'm going to take a moment to explain. I trained in general surgery for about 5 years. I am board certified in general surgery, but I really felt a passion for breast cancer patients and breast disease, so I took an additional year where that's all I did. I did a breast surgical oncology fellowship, and in that fellowship, we rotate with the medical oncologists, the plastic surgeons, the radiologists, and so I'm very fortunate because I can at least get a glimpse of everything that Dr. Rednam can do and be able to give that education to my patients. And so I think one of the questions about this is, how do we help educate patients who either undergo partial mastectomies or total mastectomies? What are their surgical options and what reconstruction abilities do we have? And to have it being started with the surgeon who knows what the options are can help also inform a patient prior to meeting one of the reconstructive surgeons. I think the one thing I do want to add is we always use the term plastic surgeon, and I think it's because it's just a shorter phrase than saying reconstructive surgeon. And sometimes I worry it gives a negative connotation that
Sure.
I'm having plastic surgery and this is so vain. And it's really not. This is really a reconstructive process. And so even though it's plastics, it's actually a plastic reconstructive surgeon. And I think that is something that we need to be more strong about, to say that this isn't plastic surgery. You're not doing this for cosmetic purposes or aesthetic purposes. You are doing this because we are rebuilding you.
That's a really wonderful way to say it too. And there's nothing wrong with wanting to look good as well with it, because
Sure.
obviously that's part of everything we do. But the idea is that yeah, we're getting you back to where you were. We want you to feel like you're you, yourself, and whole. One thing that we've all kind of talked about was that part of the problem, part of the reason that not enough women understand that their options is simply education isn't there. And Dr. Reyna, as a breast surgeon, is the person that you're likely going to hear, I have cancer from. You're likely the person that's going to say, hey, this is who you're going to see for your medical oncology. Here's some people I would like you to see for possible reconstruction. So I guess my question to you is, for people who are watching, why do you think it is that there is that little bit of a block, that there aren't as many surgical oncologists who are talking about plastic surgery and reconstructive surgery?
I think it's not necessarily that they don't talk about it. They might not emphasize it. I think it's important to know that your surgeon is aware and works closely. I think one of the things we do is we work very closely together to coordinate things. And so when you have a surgeon who works well with other members of the team, patients feel a lot more comfortable about that. So if you show that, okay, we have this experience, we have this relationship, this is what to expect, this is what you can do, it really helps the patients out with that. So I think that's really one of the biggest things.
That's true. And I feel like what I've learned the most too is the team approach is really the best approach.
Dr. Rednam, do you think it's possible for a patient to look even better than they did before getting breast cancer?
That's actually a really great question, and the answer is that's my goal. So if you have to go through cancer, things are tough, it's rough, I want to make you the best version of you that I can. So that's why I spend a lot of time talking with my patients about what their goals are, what they're hoping for. Obviously, sometimes I can't meet expectations, but I want to do everything that I can. Technical difficulties, folks.
So you look better now that we dropped the camera down. Is that what it is?
But starting over, obviously, I want to try to help meet expectations. And that's why I actually, the first time you meet me, we're going to spend about 45 minutes to an hour. And all we're going to do is talk about what you're hoping for, what your timeline is. It does make a difference. If you have a very busy job, you need to get back to things quickly, well, sometimes maybe one option is going to be a little bit better for getting you your goal in a quicker way, versus other people have different time schedules, different goals, what they're hoping for. So a lot of what I like to do at my first appointment with patients is listening to what they want.
So let's break it down. From the moment you get the diagnosis, who is the person that you speak to first?
So typically what happens is a patient has either felt a mass or has undergone a screening mammogram, that they've been called back, they've had a biopsy. Typically the OBGYN, their primary care physician, whoever ordered the mammogram and had those results are going to tell them that they have cancer. Based on that, then they will see either a medical oncologist, a surgical oncologist, to discuss whether or not they're going to need medication, surgery. So it really depends. We are fortunate enough to have a nurse navigator who can help tell patients, well, here's a little bit background, and you need to see the medical oncologist first, or you need to see the surgeon first. But all in all, typically you're going to see at least 2 of those people within their time. And so for the most part, I think I end up seeing the patients first, or surgeon ends up seeing them first, and then help guiding them through the rest of the process.
It can be really overwhelming sometimes because
Sure.
you may start with 1 or 2 doctors, but you may end with 8 doctors. And so that's why it's so important that we all talk to each other and communicate. Most of the doctors I work with, we all have each other's cell phones. It's an easy way to communicate, because it really should never be, well, I don't know what your oncologist is doing, or I'm not sure what your treatment is, because we can't really give the most effective care and
Sure.
make you feel at ease without knowing the entire plan.
let's break down some of the breast reconstruction options, because there is a lot more to it than just getting implants.
Correct. So one thing for me as a reconstructive surgeon that plays a big impact is radiation. So radiation sometimes can be a necessary part of your treatment, but certainly radiation can affect what options are the best for you. Different reconstructive surgeons are going to have a little different opinions on this. I personally feel when radiation is involved, that using your own body tissues and avoiding implants is probably going to be the best solution, because it's going to put you at the lowest risk for having postoperative complications. That's a newer area for a lot of people. They're discovering that, hey, I can use my belly and I can make breasts, but the really cool thing about using your own tissue, which we call autologous reconstruction, is that it's all you. There's no concern about having foreign bodies in you. It grows with you just like tissue would anywhere, and there's less long-term possible concern for having to worry about if I have to change my implants or not. That being said, implant-based reconstruction still is a very, very good option, and like I said, this is why there's a lot of listening and going back and forth, because you have to discover, okay, which one is going to be the right option for me.
So it sounds like, please.
So, she goes a lot into depth about this and that, and so I kind of give patients a general overview of what their reconstructive are. And so when she's talking about the autologous reconstruction, where they use tummy tissue, and she says that it grows with you, I like to tell my patients, when you gain weight, they gain weight.
That's true.
And vice versa. And so that kind of helps them understand that this is kind of a natural living thing. It's not just an implant that's in there.
Yeah. So what you're saying is you get a tummy tuck.
Essentially a tummy
and
tuck. Essentially
breasts?
a tummy tuck with your breasts, which if I have to say, for most women, that's the most appealing aspect of it.
Sure. So you take fat from an unwanted spot, like
and put it
your
exactly.
abdomen,
Take it from someplace you don't want it, and put it someplace you're more than happy to have it. So,
I have patients whose family members offer to donate their fat.
if only that worked.
If only that worked. But they're like, you need some thigh? We can help you with some thigh.
Yeah.
And I've even had ladies who say, okay, well, I'm not an option because I've already had a tummy tuck, or I've had surgeries that keep me from being able to use that tissue. Now there are other options. Over time, they've gone through lots of different things, but using your middle thigh is also another very good option if you're the right candidate for it. So having a tummy tuck but previously doesn't mean that you can't necessarily be a candidate for using your own tissue.
But what if you don't have enough fat on your abdomen?
If you don't have enough fat on your abdomen and it's just a single side, you're not having both your breasts removed, sometimes we can use something called a stack flap, where we actually take your tummy tissue, fold it, and use your entire tummy for one side. Some people are a little more endowed than others, and so we can use that little extra tissue there as well.
Truly an artist.
It's pretty amazing what our bodies are able to do if we have the blood supply. So, any questions? I think maybe we could see if anyone.
I think it's important for a breast surgeon and a plastic surgeon to have a very good working relationship together, mainly because what I do is dependent upon what she's able to do. And what she's able to do also depends on what I've already done. When we talk about a lumpectomy, I think this is one of my favorite things that we do, is when we do a lumpectomy and then someone can have what we call an oncoplastic reduction, which is basically just a breast lift on top of this lumpectomy cavity. I like to just say that I go in and I cut it out, and then she comes back and she just lifts everything, fills the defect, and it's really a nice option. I think by the time that we're done, more patients are happier and they're more excited about the reconstructive options than they have about what I have done.
Well, and I think that's definitely something that's less is known about, is that I don't necessarily have to lose my entire breast to have to expect that I could have a reconstruction as well.
That's true. I think that's not also brought up.
I just want to remind our viewers right now, for every question or comment made on this Facebook Live video, Dr. Rednam has offered to donate $1 for each of those comments or questions to breast cancer research. Such a generous donation. So we're going to jump into those questions right now. How long does recovery take for the different reconstruction options? Since there are several different paths that you could go down, are they all the same recovery time? What are we talking about?
So it's a big question, but generally recovery time, yes, it does vary. I like to tell everyone, no matter what surgery you're having, expect about 6 weeks where you're going to have some restrictions. So no heavy lifting over about 5 to 10 pounds, nothing very strenuous. You may expect to be on pain medication for 1 to 2 weeks. Sometimes for some ladies it takes a little bit longer. You may be on medication for 4 to 6 weeks. The big difference when we're talking about those two different paths is when it is implant based, you may expect that you recover a little quicker on the onset, but generally there may be more surgeries involved. So it may be a little bit more maintenance. When you're using your own body tissue, like using your tummy tissue, which is called a deep flap, when you're doing that, you may end up in the hospital for longer initially, but you have lesser surgeries over a time period, and so it's kind of like you're front loading all your recovery at that time period. I would say for the average person, they go back to work around 3 to 4 weeks for a desk job. More strenuous or active jobs, maybe more 6 to 8 weeks.
You mentioned the word deep flap. I'm sure there's people at home watching this right now. Some may be taking notes, some may be Googling things that we're going to say later. So when you say deep flap, it's an acronym and it stands for?
Correct. So it's DIEP, and it stands for Deep Inferior Epigastric Perforator Flap. It's a fancy name for meaning that we just take the skin and fat, leaving the abdominal muscles alone, along with the blood supply.
So you do not touch the muscle?
The muscle is left completely alone.
Okay. Very interesting.
I only comment on this because I recently had a patient who thought that they took the whole muscle, and so we were talking about that was one of the options a while ago, like a tram flap, where they take the entire muscle and use that because they were worried that they had to lift heavy things and they didn't want to have to do anything like that, and so they were much more excited knowing that we could leave the muscle behind at this point in time. So
it seems as though these reconstruction options are improving. And they just keep getting better.
Just like anything in surgery, we are all constant students in the science. So we all have to keep learning and to improve and to provide better patient care.
So what about tattoos? Nipple tattoos. They can do amazing things with those. They can make them look like they're 3D. Do they last forever?
So like most tattoos, you have to touch them up over time. But nipples I find are a really fascinating topic because people are just fascinated that you can recreate a nipple. The best way I can describe how to create a nipple is like origami using your own tissue. So after things have settled and healed, I rearrange little tissues to make the nipple. The areola, which is the colored part, the larger circular part of the nipple areolar complex, which is the full term for that area of the breast, is tattooed on. So the more standard method is to do 3 or 4 sessions in the office where we do medical grade tattooing to match a color similar, and this is where you get to be creative in anything you like. But the newest method is 3D nipple tattooing. I still recommend that you have a nipple created even with the 3D nipple tattooing because it's going to give you the best effect. But what's so cool about 3D nipple tattooing is that you can actually see the little glands that are on a normal areola. You get more depth to it, so it looks less of 2D cartoon kind of drawing and more of that your natural full-shaped breast. And that's still something that's done in the office, still something done, you come in for an hour, sit down, chat, relax, get touch-ups. Likely you're going to have touch-ups maybe every 10 years or so because the color can fade over time. Just as skin sheds, the color can kind of slowly fade. But we've come a long, long way. It's no longer just a stamped-on looking areola.
Okay, I can't type in, so I'm gonna put in my question.
Okay.
My patients are always asking me if it hurts.
So this is one place where I can say, no, we do not hurt you. The nice thing is, obviously, your sensation changes a lot, which is actually something good to talk about as well. A lot of people are surprised afterwards that, oh, well, I lost my sensation. You are going to lose your sensation because with the breast coming out for the cancer treatment, you're going to lose a lot of the nerves as well. The amazing things about our bodies is that we regrow a lot of things, especially sensory nerves. So it may take over a year to come back, but you do regain a sense of sensation. But luckily, it's still a dull enough sensation that even with the tattooing, it can be very, very comfortable. For ladies who do get some sensation back, we use a topical cream, so it's a completely painless process. Literally to the point that we have ladies come in, get their tattoos in the morning, go back to work in the afternoon.
You did mention that you still recommend having the person rebuild their nipple. So there's a couple ways that you can do that. Do you want to talk about how you can rebuild a nipple? Because that's amazing.
So like I said, it's just a kind of origami. I'm using the tissue that I have there and rearranging it, and it's using your own fat to kind of give that fullness to the nipple. Obviously, a reconstructed nipple is not the same as a natural nipple, so it doesn't become erect when it gets cold or with stimulation, but the appearance is still there, so it still has that natural appearance. If you do a 3D nipple tattooing without creating any sort of nipple, obviously if you touch your breast, it's completely flat.
Okay.
Most women like to have that feeling that it's a full breast mound with a natural feeling nipple. And so that's why I still think if you create that nipple, you still have that tactile feeling of a natural breast mound. But you're going to get that even more amazing look by doing the 3D tattooing on top of it.
Interesting. Do you use other body parts to recreate that nipple like you do with the fat to?
You can, and as many plastic surgeons as there are in this world, there are different ways to recreate nipples. There are some people that will also use a little bit of the ear cartilage sometimes that they'll put inside there to try to give a more robust appearance to the nipple.
Yeah.
But this is kind of, ladies, where you get to have your say. I have women who say they hated having to hide their nipples forever and they don't want to deal with it anymore.
Sure.
Well, then just get the tattoo. You have the appearance, but you never have to worry about putting Band-Aids on there or covering anything up again. So, and then I have ladies too that say nipples are just, I don't want to go that path. I want to do something else. So this is your time to express yourself. So if you want butterflies, you want something else, you should get to do whatever you want to do.
No, I was just, by this time, they're having their nipple reconstruction. They're pretty much done with their cancer treatment. Some patients are almost sometimes a year out because it can be a long process in order to get this all done. What I like to tell them is this is the fine tuning. This is the fun part. This is, if we're looking at these little things like, do I want a nipple, not want a nipple, we're in a good place in terms of your cancer care. And so this is the time to be fun, to express yourself. And so I think that's a good way to put it for them.
And the nice thing too is there's no time limit on this. So if you felt like I need to wait a few years before I want to go on with my next stage, you can. Like I said, this is your right to have reconstruction, and you can do it to a certain extent on your own time period when you're ready for things.
Can I get my breast reconstruction done at the same time as a mastectomy?
In many cases, yes. Dr. Reyna and I will often work together, and this is where that team planning comes in to discuss, okay, this is what we're thinking about doing. Is it possible for us to do it together?
Is that the most common route? I mean, you just said people kind of do it on their own time. They're allowed, to come back and get reconstruction years later. Would you recommend that sort of process for them?
We'll see. Well, let you start with this.
Well, and so it really determines on the fact of what type of mastectomy are we talking about. There are really 3 types of mastectomies that at least I personally perform. A total mastectomy, and that is what I think most people think of, where we take the skin, the nipple, and you end up flat and don't have reconstruction. Then there are newer options that are out here that are skin-sparing or nipple-sparing mastectomies. And what that is that with a skin-sparing, we basically remove the nipple, leave all the skin intact, shell out the breast tissue, and use your own skin as part of your reconstruction. A nipple-sparing mastectomy is just this. We leave the nipple, we leave the skin, we take out the breast tissue, and we use all of that as an envelope for your reconstruction. And so I think that knowing those options of what you can and can't have in terms of mastectomies also help guide whether or not you can have it at the same time.
So I think that's the best way of saying it, is depending on what type of breast cancer treatment you're having, surgical treatment you're having, what your options are. Obviously, if you're doing an option where we're leaving the skin, I don't want to lose that skin. It's amazing, like I said, how our bodies can heal quickly. If you let that skin sit there without putting something in its place to hold that place, it will start shrinking. So generally, if we're talking about a skin-sparing or a nipple-sparing mastectomy, then we are doing some sort of reconstruction immediately. Literally, it could be that your definitive reconstruction is all one step. So if someone is having a nipple-sparing mastectomy and they decide they want to have a direct implant, which means we just go ahead and we finish your reconstruction, you might have a single-stage reconstruction. If it's something using your own tissue, it may also be a single stage reconstruction if we're doing nipple sparing. But suppose we're doing skin sparing, well, then we're just kind of creating that breast mound, and then we're going to come back another day and do nipples. So, yeah, there's also the in-between process where we might put something called a tissue expander in, which is just a place saver. So it's holding that space until maybe a patient has radiation and then comes back after radiation is completed to do a reconstruction. Or it might be that we're just trying to adjust the shape until we get to a size that we're happy with before we put implants in finally.
I think of tissue expanders kind of like a balloon. Basically, as you have a pocket that I've made with the skin, they close everything up, and they have this balloon, and they kind of fill that balloon until they get to a point and that you're happy with, that you're both happy with, and then they can kind of change that out. I think if you say tissue expander, people are like, I don't know, what are you doing exactly? And so it's basically a balloon that stretches out the skin to get to the point.
Mm-hmm. So is it possible for a small-breasted woman who has breast cancer to get implants that are even bigger than what she started?
Certainly.
With the help of
certainly, and I've had ladies who have had big breasts their whole life, and they can't wait to have smaller breasts. And women who have small breasts who can't wait to have bigger breasts.
Yeah.
This is your chance to have the breasts that you've always wanted.
Yeah.
And for many ladies too, that it's just not the right time. They have their mastectomies, and it's just not the right time for them to have reconstruction, and there is no limit. So you can wait 20 years later and say, hey, you know, I think I'd like reconstruction now. It may change our options a little bit, but it doesn't mean that it's ever too late.
So that begs the question, is there an age limit?
No.
To breast reconstruction?
There is not. When someone comes to see me with cancer and I start speaking to them about what their options are, I never let age be a limiting factor. It doesn't matter if you are 37 or 77. You have the same options as long as we feel that it's safe to do the procedure. So in that regard, I can tell you that I've had people in the upper age boxes that have had reconstruction autologous, and it doesn't mean anything if you're just older. It just means that we need to be more thorough and make sure that you're healthy enough to do it, and if you are, there shouldn't be anything that really limits you.
Great. I would agree with that. The only limiting factor sometimes is just your general medical health, because
and smoking,
which is part of that. But the idea is, Dr. Reyna's part of surgery is absolutely needed. We need to remove the cancer. I like to believe my part is very important, and it is, but it's not at the end going to cost your life if you don't have my part of the surgery, which is why I can't ever put you at additional risk unnecessarily, which is why I want patients to be as healthy as possible before we go on with reconstruction.
Let's talk about risk. Let's talk about what are some common complications that happen during the breast reconstruction process.
That is a very good question as well, because you have to be prepared for everything.
Right.
Mm-hmm. So early on, let's talk about smokers, since we just kind of brought that up.
Yeah.
So
that's what I always hear from you. Does she smoke? Wow.
So
she quit 2 days ago.
So
it's a good start.
It's a good start.
It's a good start.
Very happy.
There are many, many reasons why smoking is bad, but for a plastic surgeon, the reason that smoking scares me so much is that for every one cigarette for 90 minutes, your skin does not get the same amount of blood supply it normally does. So basically your skin is starving. Now you can imagine Dr. Reyna does a mastectomy.
A beautiful mastectomy.
She takes out all the breast tissue. Well, now all I have is skin with a little layer of fat. And if that skin is starving, it's going to have problems.
Sure.
So what happens as a complication of that is that we could lose some of that skin, where actually portions of the whole skin die. You're more prone to infections because of smoking. You're more prone to infections, which again, if I'm putting a tissue expander or I'm putting an implant in there and I get an infection, that might mean me removing those temporarily. So that's my biggest concern when it comes to smoking initially. But in general, let's say you are the healthiest person in the world, you run marathons, it's not to say that you can't have complications. So, wound breakdown can happen as things are healing. There can be small minor infections that can happen. I would say majority of risks can be treated in the office, either with antibiotics or with love and wound care. But there are bigger complications sometimes that mean that we have to remove things and we have to delay reconstruction or even stop reconstruction. It's not the norm, but you always have to be prepared that these things could pop up.
Sure.
Absolutely. Yeah. I hear some typing over there, which means I think we have a question coming our way. We've actually had very good questions
Definitely
so
appreciate
far.
all of your questions right now. Well, my health insurance
I've been
plan.
waiting
This
for
is
that.
the insurance topic is important to talk about because insurance is confusing. Will my health insurance plan cover the cost of breast reconstruction?
I totally punt that over to you. Surgery usually is not a problem for cancer.
So the answer is that there was an act passed that says that if an insurance carrier offers treatment for breast cancer, so what Dr. Reyna does, that they are legally required to offer reconstructive options. Now, that sounds perfect, right? So I can do whatever I want. Unfortunately, depending on who your insurance carrier is, it can be easier in some situations or not. But I will tell you the short answer is yes. If you have insurance and you are approved for treatment for your cancer, which you would be, of course, then you should also be approved for treatment for your reconstruction. There's a lot of questions about, well, I want to see this doctor, but I don't know if they're in my network. This is where things get really, really confusing.
Yeah.
So the answer is certainly if your doctor is in your network, which means that they have an agreement with that insurance company to treat patients who have that insurance, then the answer is yes. It's pretty simple, it's straightforward. You should be able to get the type of reconstruction that you're hoping to get. Now, the hard part comes when, I want to see this doctor, but they're not in my network. Depending on whether you have out-of-network benefits, that's where it gets a little murky. If you do have out-of-network benefits, then you can still see a doctor who's not in your plan, but your pricing might change because your insurance company obviously would like you to go to someone in their network. That being said, I've taken care of patients both in and out of network, and most doctors will try their best to work with you to make it plausible to have the doctor that you want. Because I think at the end of the day, anyone on your care team should be somebody you trust and someone you feel comfortable with, not someone you felt like, well, I had to go to them because they're in my plan.
Okay, what if they get denied by the insurance company? Is it possible to appeal and get approval then?
Yes, there is still possible. So what happens is, let's say I submit for insurance and they say, no, you can't do that, or you can't do that specific type of reconstruction. There is an appeal process, which eventually ends in me actually talking with a doctor that works at that insurance company. So I'm fighting for you to get the reconstruction you want. And I like to think I win most of the time, but there's just times when it's out of my control. But you want to make sure, again, that you have a team that's going to fight for you, because I want to make sure that I'm able to provide you the care that you want.
What should someone look for in a plastic surgeon?
That was going to be
a
my
breast
question.
reconstruction surgeon? We are so on the same page. I love it. Yeah.
So I would love to think that I am the best plastic surgeon for every person out there, but that's probably not the case.
Probably
not the case.
not the case.
But that you have to find someone that you trust first and foremost, because you are putting your body and your life into their hands. You need to make sure that you have someone who's very open about everything. I always tell people, I don't have gray hair yet. I can't tell you I have 20 years of experience.
Why would you say it?
I have some white hairs, I'm not going to lie. But the idea is that I want people to know that I have experience, but I haven't been out for 20 years, and I'm very upfront and honest about that. You have to be willing to have a doctor who's willing to show you photos, willing to show you, or even to talk to previous patients. Because if you ever notice hesitancy, or they're not sure, they don't want you to talk to people, then that's a reason for concern. But at the end, you have to never feel bullied. I have heard from other women that, I talked to this doctor and they said this is what I had to do. And obviously everyone has opinions. I have my own opinions, but you should never feel that you're being pushed into something that you don't want to do.
We talked a little bit about the nipples earlier, but someone asked, will they regain sensation in their reconstructed breast?
So we both see patients quite a while afterwards.
Yeah.
Yes and no is the best way to say that.
From my perspective, if they have a skin-sparing mastectomy, they will have sensation up to a certain point. The closer to the incision you get, the less sensation I believe they have. And it's been pretty consistent throughout. And yes, you recover some, and even over time, it's not going to probably be that same very sensitive sensation. It might just be pressure versus not pressure. So yes, you have sensation up to a point, but the closer you get to the incision, I think it comes down to pressure versus no pressure, but sometimes not at all.
Right. And I kind of describe it as it's just protective sensation that hopefully and like I said, it can take over a year sometimes to get to that point even. But that if you have your hand on your chest, okay, I have my hand on my breast.
Right.
But it is a letting go. It is letting go because things are never going to be, even if I can get you physically to look the same, things are never going to be exactly the same. Just because unfortunately we can't recreate those nerves, we can't recreate that exact sensation.
I think the same is for nipple-sparing mastectomies. The important part about a nipple-sparing mastectomy, I think, is you're going in order to keep your nipple and to keep that look. Sometimes you have function, sometimes you don't. I would say for the most part, everyone's different and the recovery is different.
And that's a lot of too, when you go in for consultation, these are the kind of questions to ask because you want to know, it's so hard waking up and having no idea about anything. So you want to be prepared for what's it going to be like my first day? What's it going to be like 2 months from now? So the more that you know, the less scary the whole process can be.
And how long is the postoperative period? I mean, are you following up with these patients for the rest of their lives, or at some point, are they good to go on their own?
I tell my patients that I am now one of their new lifelong friends.
I love that.
That I typically see a new patient about every 3 to 4 months after their initial surgery, just to make sure that they're seeing their medical oncologist, the radiation oncologist, making sure we're keeping on track of their cancer care till we hit about the first year's finished. After that, it's about every 6 months, and once we hit that 5-year, we go back to yearly. But I never say that they get to leave me unless they choose to.
I have a similar relationship early on. I sometimes will see patients almost every week. Then we kind of go out to every 2 weeks for the next few months. And then once we get to that about 6-month time period, if you're completed, granted, the timeline for reconstruction, again, depending what time you have, it may be 2 years before we completely finish a reconstruction. So I get to be someone you know very well. But even after that time period, we go back to yearly, and I like to see you very often. So the idea is once you're my patient, you get to be my patient forever.
I think one of the things on top of that is, we work with each other and we see a lot of our patients together, but you'll be surprised about how 6 months to a year later, the patients are asking for their surgeon's opinion of, do you think I need nipples? Do you think I need to do this? And knowing what is available, it helps the patient understand, and it helps me educate the patients as well. And so I think just making sure that whatever surgeon you work with understands what options are there, because it might not be right now. It might be 6 months down the line or 1 year down the line. And I just think it's funny because I don't think you understand that they come in and they say, well, what do you think? They talked about making nipples, I'm just not sure about it. And so knowing what it is and being able to walk them through that makes them feel more comfortable with whatever decision they make.
Yeah.
Will breast reconstruction interfere with radiation therapy?
So, in general, breast reconstruction shouldn't. It's actually the opposite sometimes. Breast reconstruction less interferes with radiation as radiation interferes with breast reconstruction.
But it's always cancer care first.
It is. It
always
is,
cancer
and that
care
is the
first.
most important thing. I will say that there are times where radiation can change things a little bit depending on where they need to radiate. And the average person, no, you can still go along with reconstruction just like you would. But sometimes depending on if they have specific areas that they need to reach that a reconstruction would be obstructing, then obviously radiation first, and then we talk about reconstruction later.
So I think sometimes people want to know, well, what's the timing of everything? How long after my surgery? How long after my chemotherapy? How long is this? So really, what is kind of the overlying time process? So when it comes to cancer, sometimes we do surgery first and sometimes we give chemotherapy first, or we give some kind of medication first. If you're doing the medication first or chemotherapy first, we usually wait 4 weeks for surgery. And then depending on the type of reconstruction, sometimes we do that before you need any other treatments, including radiation therapy. So when we said earlier that this is a process, it could just be because you're getting one treatment, now we're doing our surgery together, part of it, and then you're doing radiation. Or sometimes I need to do my part of the surgery, you need to finish your radiation therapy, and then get your reconstruction. So sometimes it can be a longer process.
So I'm sure you kind of gather it can get a little confusing sometimes, which is why again, we talk a lot to make sure, okay.
We draw pictures.
We draw pictures, we talk a lot, and give you lots of resources so that you understand kind of what's happening. Generally, when radiation does have to occur, whether it's in the middle of reconstruction or before, after, we have to wait almost 6 months sometimes because I need your body to heal from the radiation before we move on with things.
Speaking of the healing process, we have so many wonderful questions coming in. Really appreciate that, guys. Keep them coming. Will there be pain, scars, or any other changes in the parts of the body where the tissue was taken from? So like with the deep flap reconstruction option, for example.
If you can operate without scars,
We'd be amazing.
We'd be amazing.
We can do a lot of things to make scars look better. So a lot of my care afterwards is, once things are generally healed, is scar care. So how do we maintain the scars? How do we make them look as pretty as possible? I will tell you, yes, there will be scars. I will do my best in working with you to try to make them look like the best possible scars. An ideal scar is going to be a thin white line that isn't raised or firm to the touch. How long is it going to take to get there? That can be 9 months to a year before you get to that scar. Everyone's bodies are a little different, so some people tend to make thicker scars, or some people can even keloid, where the scar actually grows out of the boundaries of an original scar. When that happens, there's still options to improve the scar and make it better, but it's just knowing that some parts of things we have a lot of control over, and some parts we just have to kind of give patience and time and see what kind of happens. As far as when I remove the tissue from the belly, generally no, there's not any long-lasting effect because I don't take the muscle and I leave that tight fascial layer deep down that is responsible for kind of giving you the internal hug, keeping everything in where it needs to be. Generally, there's less concern risk for things like hernias. But that being said, I've had some ladies who do end up having permanent numbness sometimes just around that incision, which is not unlike how you can with a mastectomy. But for the most part, I would say most people are able to go back after things have fully healed. And like I said, sometimes that might be waiting 9 months to a year. You go back to life just like it was before, if not better.
So if you have cancer in one breast and not the other, will the reconstructed breast match the other breast?
That's a good question. The answer is it can. Again, depending on the type of reconstruction you decide to have. It will say that if you have very, very large breasts, sometimes it is much easier to match when we're using your own body tissue. But generally, if you're having a single side treated, both sides are treated. So even though there's no cancer in that other side, again, from an insurance standpoint and a reconstructive standpoint, your breasts are a pair. I tell all my patients they are sisters, not twins. So nobody's perfect.
That's good. I made them cousins, so I guess that's better.
Nobody matches perfectly, but the idea is they should look pretty darn similar.
So, this might be aging me, but I think of like Patty Duke and like the identical cousins.
Exactly.
Yeah,
there you go. That aged both of us.
I know I did.
So, but the idea is that even though it may not happen at the exact time that you have your initial reconstruction, eventually I will lift up the other side to work to match them to make them equal.
Great.
Yeah, that's really all on her. I don't make them equal. Oh, we wrapping up.
Oh, yes.
Is that the signal that we're giving?
Thank you so much for joining us. I just want to remind everyone that every comment that you made and question that you asked, Dr. Rednam is donating $1 to breast cancer research. So let's give a round of applause for that. So generous. Thank you so much, Dr. Reyna, for joining us today. Thank you, Dr. Rednam, and join us again for our next Facebook Live.